Yeah,
firstly.
from the first one.
Yeah,
Acha.
yeah, yeah.
Good morning, good afternoon, and good evening to all the viewers from all over the world at different time zones. Today, we are talking about the upper limb of individuals with cerebral palsy. My predecessors have already explained you how to improve the control, how to measure various phenomena of the upper limbs, hands, and my another colleague has very rightly mentioned to you that how these can be corrected with the musculoskeletal approach. I, as a neurosurgeon, would like to explain you regarding neurosurgical procedures which can help. Please just have the challenging thing in these cases is that these are different pathophysiological types of the hands. And not only one, it can be mixed type, and they can be one side or two sides or whole limb. It depends demographically. Also in the upper limb, whether they are very much focal distally or they are proximally causing the dystonia. Like this, physiologically as well as demographically, the upper limbs have differences in various individuals with cerebral palsy. That what you see in dystonia, that it is not only the normal hand is left alone to work, but in dystonia there is that the normal one has to control even the abnormal one, and it gets engaged. It is not able to work for the activities. Not only this, even this girl has hurt her own thumb with her nails. She could not control, and following that there was a pain, and the pain has worsened the dystonia, and there was a vicious cycle in this particular individual. Similarly, you can see how one has to control the limbs, otherwise whole body get uncontrolled because of the dystonia in that. So we have seen now how the spastic and dystonic upper limbs are challenging. And today, as I explained, we have a quadrivalent vaccinoid approach in this era of corona. So you have already know about my two predecessors have explained you, and I, as a neurosurgeon, would explain you regarding the neurosurgical approaches and which one is the final quadrivalent B, we will come to know at the end. So this is the procedure called as motor fasciculotomy for these spastic dystonic upper limbs of cerebral palsy. Before this neurosurgical procedure has to be understood well, we have to understand that the all the time entry horn cells like a volcano keep discharging impulses to the muscles, and they go into spasm or dystonia. But normally what happens that these are being inhibited by the brain upper motor neurons suprasegmentary. And with that, we have a normal tone, but because of the damage in cerebral palsy, there is no more inhibition. Then we find a spastic or dystonic muscles, say, for example, of the upper limb. There is an botulinum toxin which acts at the myoneural junction and temporarily for few months blocks the excessive transmission. We as a neurosurgeon in the peripheral nerve dissect the motor branch of the peripheral nerve, and the component fascicles are ablated. That is called a selective motor fasciculotomy. You have already discussed about what is called as soft tissue release or any of the orthopedic procedures. So these are the ablative procedures which we have talked about, and this is the non-ablative procedures. So these two is a direct neuro approach for the spasticity and dystonia. Before we go for the neurosurgical procedure, the selection of individuals with cerebral palsy for SMF, there are two very important notes. One is to be remembered that is an ablative procedure, no return. Done can not be undone. And next that it modulates only tone. It does not do anything with the control in de novo. It cannot increase or improve the control or the balance. Yes, it can unmask with the relief of the spasticity or dystonia. Now, in the selection, this full scenario should be in our mind for an individual with cerebral palsy according to the age. Remember that the therapies, orthotics keep playing the role throughout their grown-up age, say for example 20 years or sometimes even more. Next are the non-ablative procedures which come into picture a little later after 2-3 years, and there are various kinds of the neurosurgical procedures, non-ablative also. Yes, but once the good therapy have been taken place, then we have ablative neurosurgical procedures like SMF, which will be not the throughout a particular period of the growth where this procedure to be performed. And when a maximum growth has taken place by the 8 or 10 years, and then orthopedic plastic procedures plus minus neuro procedures keep playing the role to correct the fixed deformities, organic shortening. So the scenario of all these things play a role in these children. Well, for the selection of individuals with spasticity, non-progressive, harmful, and resistant to all other non-ablative procedures, is it focal spasticity affecting only the particular group of muscles, say wrist flexion or elbow flexion, or they are hemi who have the lower limb also involved? Chemodenervation like botulinum toxin and selective motor fasciculotomy. So once the resistance to all others have taken place, then SMF comes into picture. However, for the upper limbs, please remember that focally harmful involvement the upper limbs where we do not have well published or well practiced selective posterior rhizotomy, we have what is called as the multiple fasciculotomies of the upper limb. We have done cervical SPR, but now we do not do it. So for a spasticity of the upper limb, see how focally which one is more harmful and then go for resistant cases to SMF. However, for the upper limbs, even both the upper limbs involved, diffuse involvement, find out which are the harmful muscles and then perform selective motor fasciculotomy. So we do combine with sometimes the soft tissue release or other orthopedic procedures. Both are complementary to each other, and that is why the concept of neuro orthopedic approach is going on in our group. Well, to give you just a glimpse that how in the upper limb, say for example, here we can perform a surgery, and this is the median nerve has been exposed over there, and we are stimulating different fascicles to see the pronation, say for example, or wrist flexion, and that is how this procedure is done. In this procedure, the fascicle is dissected, and then after dissection, stimulation, and checking up whether this was the preoperatively harmful muscle or movement, then we section those particular fascicles, only some of the fascicles, usually 50% plus minus a little bit more or less. So I will not go into much detail. This is cut, and then we coagulate this one, and you can find after this stump is coagulated, and so that the recurrence does not occur, and we have not faced any kind of a what is called as recurrence in these cases. So this is how the small fascicles are taken out, or you can see here so many fascicles going into the muscle, and these are dissected and then ablated. This is, say for example, what will you do for this child which is having diffuse involvement in both the upper limbs, and this is what has happened after selective motor fasciculotomy. For the elbow flexion, for the pronation and wrist flexion, his ADL has improved. He is quadriplegic. We did publish, first of all, in 1998 after 4 or 5 years of our experience, and conveyed a very particular name for this particular surgery as selective motor fasciculotomy, because this gives you an idea that you are going to the fascicle only to ablate them, not the selective neurotomy means not the nerve. So this is how it was accepted. This is one of our series where initial one, we had our these children, and you can see that how the spasticity has decreased and how the control has improved. So this is the way post-operatively you can find, if perfectly done, the voluntary control also improves. Not only this, even at the finger, you can find how the opposition of two finger improves, fourth finger improves, third finger improves, fifth finger, yes, we don't use much, and that is what is not that much change occurred. Similarly, the grasp of different sizes of the instrument or rod has also been shown that even 2 inch or even ½ inch does improve after selective motor fasciculotomy of the hand muscles. And this is what? Here we can see that how badly this limb is affected, and then she has to also keep it controlled over here. This is what post-operatively. She has a free movement here. But I must tell you, it is not only these SMF, we have done soft tissue release surgeries also in the upper limb, and both the surgeries are complementary to each other. So we could like to say that in spasticity and dystonia does get reduced, the residual motor function which is there get unmasked and improves the functional abilities, makes passive movement much easier, appearance improves, and the procedure is very, very safe, very small, fine incision, not a much mutilation of the tissues around, and we have not found any recurrence, and it is very cost effective permanent procedure. Now let's discuss a little more about the dystonia, which is much more challenging from the point of view that sometimes the orthopedic procedures which are done on these dystonic muscles, they worsen, and dystonia does not get relieved because of the excessive impulses going to them. So again, I would talk not about the generalized one, which you see in those cases, intrathecal baclofen pump is the most important one. However, when they refuse or some of the things, in some cases we go for SMF. Otherwise, for a focal or segmental of hemidystonia, we have to select the most harmful one. And that muscle group, say for example, wrist flexion, then trial with bupivacaine or sometimes botulinum toxin or sometimes phenol. With that, we see that how good the relief is coming. Once we are very sure, then we go for staging SMF. Say for wrist flexion, median nerve initially, not the ulnar nerve we have taken. If there is still a residual harmful impairment or dystonia, in that case, either we re-explore the same nerve or we go to the another nerve, say for example, ulnar nerve. And that is how we try to relieve the wrist flexion problem. And similarly, pronation, similarly, by musculocutaneous, the elbow flexion. These are the, on the surgery itself, we have to examine on the table that how is the muscles. And you can see that those which are dystonic will be easily, we will be able to move. But those which are having spasticity, say for example, fingers had spasticity, and that is why they are still under anesthesia, not getting totally relieved of. So they mostly will have spastic dystonic cerebral palsy, and the combination of the two, based on that, we have to decide how much is to be done. Say for example, you can see very clearly on the table the pronation which is occurring, and this pronation which is maximum harmful to the patient, then the individual, then we have to go for that one. But instead of that, you may find that it is not. There may be some another movement which may be clinically found harmful, and that can be also taken care of. Say this is the wrist flexion. So it helps tremendously on the table to again stimulate and see particular individual muscle which we can target and take care of it. Right? So this is how on the table selective motor fasciculotomy is performed. Now, sorry. This is the girl which we have just now seen about it, which with some conservative treatment, her hand improved, and then we have taken up for surgery, and you can see that how clean it is with the surgery after few months post median SMF, and you find that she who had the problem has found that she is much more better with the surgical procedure of dystonia. Uh, this is what afterwards she is able to move it much more freely compared to what it was earlier, which she was not able to move. This is the another boy of 26-year-old had a generalized cerebral palsy, but we have found that he has the very harmful dystonia of this particular hand and extension. So we have gone for a radial nerve ablation, and then we could improve about it. So you have to select that particular target, the one which is a harmful dystonia. It requires a lot of staging of these surgical procedures. And here you can see how after the surgery he is able to move his limb like this, able to flex voluntarily. He is able to hold the things also much more better way than what he was doing earlier. This is another one where somebody has done the rhizotomy, cervical rhizotomy for the dystonia one. Then we perform our surgical procedures of SMF, and you can see how well he has improved and felt very confident and good after the surgery. This is just recently, yesterday he has mailed me his picture that how good he is. But you can see he is still keeping his hand into the pocket. And I asked whether it has become more comfortable. He says, yes, yes. Earlier, this was also not possible to keep in the pocket. So somewhat by trick, these people improve their dystonia and get relieved and go to the streamline, and he goes to his job. So this was one of the chapter which we have written, ablative neurosurgical procedure in progress in clinical neurosciences. We can provide this one. So what I would like to say that what is that last B which we were talking about? A and B we have talked about the trivalent, and this fourth B of the quadrivalent is B positive. If not hands, you have feet even, and that is what we can see. Some of these individuals with cerebral palsy have so much motivation. They are so positive, motivated, hopeful, and humorous. I think that will also play equally important role in the management of the upper limbs. With this, I thank every one of you. Thank you very much.